MRD has been on the table for several years now in myeloma. I worked on it for over 15 years. We came to a consensus in the field of experts in 2016 to publish the first iteration of the International Myeloma Working Group guideline, and that was in the summer of that year in Lancet Oncology. Shadi Kumar was the first author. In that study, we agreed that 10 to minus 5, or to rule out one cell in 100,000, is a reasonable threshold, and we agreed that you could use either flow cytometry-based assays that are validated, or you could use next-generation sequencing-based technologies. That is still the text we have in writing. It's in the NCCN guideline. It's internationally accepted. But we also know that if you jack up the sensitivity to 10 to minus 6, so 10 times more sensitive, and the patient is MRD negative, that there will be a difference in progression-free survival in favor of 10 to minus 6. So there is no doubt that with more sensitive tests, that's going to be a better tool. The problem is that not everyone has access to those assays that are this sensitive. For that reason, we are still keeping the guidelines the way they are. But we, of course, endorse experts in the field and groups around the world to implement more sensitive assays and make sure when you publish your data that you spell out that with 10 to minus 6, these are the results we have. I think we will see very soon more and more blood-based technologies. Here at the meeting, there are several groups using mass spec. You can look for fragments of mass spec. There are technologies with clonotypic proteins, meaning that you can look for patient-specific proteins that are a result of the tumor's genetic signature, if you want. And there are also, of course, studies here looking at circulating tumor cells. The Menarini program is very powerful. The CBIA program is very powerful. The binding site program is powerful. And there are many others. You can look for circulating DNA. So my bottom line is, we have come a very long way. There's much more left. I think the next important step will probably be to integrate blood-based validated tests in clinical management. And then we can start designing studies on a broader scale using MRD for treatment decision. And I think that is going to happen.